alterations, and also inactivation of tumor suppressor genes. These are three main areas in which people have been noting new progress that's been made. So if you have an older version of a textbook, some of these features will not be addressed to any extent. Apoptosis will not be addressed. Oncogenes are a relatively recently expanding field, and the cancer suppressor genes, like the P53 that was on one of those questions that I gave you, these are recently evolving processes that are in rapid change. And when you have the altered gene process, this has to be an alteration that allows the cell to grow, because a lot of these mutations that occur actually result in cell death and elimination of the cell. Only a subset of them allow for the stable expression of this mutation in a way that allows for clonal expansion along with the other malignant potentials. Okay? There are a number of carcinogens that have been identified. Two big categories of carcinogens are initiators and promoters. And we'll discuss very briefly, this is a feature that's played on heavily in terms of whether or not a carcinogen is an initiator or a promoter. If you initiate and you don't promote, you won't get a cancer. If you promote without initiation, you won't get a cancer. You need both something to cause a change and then something to induce that change to be a neoplastic change. This is an example. If you have an initiator that comes in here and nothing happens after that initiation, you do not develop a tumor. If after you have an initiator, you add a promoter, here you create a change in the cell. You don't change it, it doesn't grow. Here you create a change, now you add a promoter which induces proliferation of that altered cell. That induces a tumor. Sometimes you can have to add that promoter shortly after it, or if it's a stable change that initiates, you can wait a long time and you'll still get a tumor. If you reverse the order of these, you will not get a tumor. Or if you have only the promoter and no initiator, then you won't get the tumor. There are circumstances in which the combination doesn't result in a tumor, but the important thing to remember is that if you have initiators without promoters, they won't grow. And there are a number of initiators and promoters that have been described. This one, classically, the initiator here happens to be a polycyclic hydrocarbon, and the promoter is croton oil. I'm not going to spend longer on that, but you should be aware that there are certain substances that have been identified as initiating the change in the genetic code of the cell, and then promoters which initiate the actual growth of those altered cells. There are a number of inherited cancer syndromes that have been identified now, and there are some causes that have been, or at least alterations in the genetic code that have been identified. One of the most famous is the retinal blastoma, where there's an inheritance of the retinal blastoma RB gene, and we'll discuss that very briefly also. The familial adenomatous polyps of the colon, in which these adenomatous polyps almost always by age 50 end up in malignant transformation. There are other types, neurofibromatosis. We'll focus on these two just briefly. Here we have an individual who has familial polyposis. You see here that there are a number of these polyps, some of them different size. These are adenomatous polyps. They are benign lesions as they appear here. However, because of a genetic defect in this individual, the ability to produce these has a very, very high frequency of malignant transformation. I'm not sure about whether or not these may be malignant transformations. By age 50, virtually 100% of these people with familial polyposis will develop a malignant carcinoma of the intestine. So this is a genetic defect which is inherited and gives all of them lesions in the colon which, if left alone, will lead to cancer. Here we have a brief description of what happens in the pathogenesis of retinal blastoma. This is a tumor which usually appears in young children, in which the retinal cells cells in the retina get transformed and you get a malignant tumor of the eye. These individuals carry a somatic mutation from one of the parents. It is an autosomal dominant, so therefore you only need to have one copy of the mutant gene. What happens is that these individuals are at high risk because they have a mutant RB gene, which in all of their cells, and if they have some additional mutation that comes, and often it comes early in life, you can get a cell which now has two copies of the mutated gene. And so these individuals have a very high frequency of tumors of the retina. They also have high frequency of other tumors, including ovarian cancers that occur later in life. So this RB gene was one of the first genes that was discovered as being an inherited cancer predisposition. But you need to have an additional change in the cell in order to manifest the tumor. There is also a sporadic form in which you have to have two hits to the cell in order to somehow get a mutation that in both copies of the gene. The reason these people have such a high incidence of tumor is because they already have one mutated copy before they start. Okay? In addition to those tumors which are in which that we know that there's an inherited gene, there is also familial cancers where there's a clustering of cancer where the role of the inherited predisposition may not be clear in that individual. And they include some of the breast cancer, ovarian cancer, and colon cancers other than the familial adenomatous polyps. And a number of groups have been studying these intensively. And as you may be aware, and one of the questions that was asked on that quiz was related to the familial Li-Fraumeni syndrome in which the p53 gene is altered.